Phenoxybenzamine and phentolamine are both non-selective alpha blockers. Phenoxybenzamine permanently binds alpha receptors, while phentolamine is a reversible antagonist. Now, the famous vignette about phenoxybenzamine is to always give it pre-operatively before you are about to surgically remove what type of tumor. How about a pheochromocytoma? On the other hand, phentolamine, because of its reversibility, it is given to help temporarily block alpha receptors in patients that accidentally eat tyramine-containing foods while also on a monoamine oxygenase inhibitor. Now, the side effects of these drugs are directly related to the mechanism of their action. So, for example, if you excessively block alpha-1, you can potentially cause a significant drop in the total peripheral resistance. And remember, blood pressure equals the cardiac output times the total peripheral resistance. So that means we get a significant drop in blood pressure, or hypotension. Now, this hypotension can trigger the baroreceptor reflex, and we have what? Well, we get a reflex tachycardia. The orthostatic hypotension is related to inhibiting the vasomotor center within the medulla. If the brainstem cannot regulate your blood pressure when you stand up all of a sudden, expect to get dizzy when standing because the brain is going to be hypoperfused. The selective alpha-1 blockers all end in OSIN. I wish they could do this for all the drugs. You will only be asked about this drug in reference to mechanism and side effects, period. Just like the non-selective alpha blockers, we are worried about excessively blocking the receptors we are targeting. But in this situation, we're only worried about alpha-1 receptors. Now, this alpha-1 receptor antagonism leads to a drop in the total peripheral resistance and therefore a drop in our blood pressure. This hypotension can lead to risk of passing out, hyperperfusing the brain. This can present as dizziness or headache if it hasn't progressed to the point where the patient passes out. Now, these drugs were designed with the goal of relaxing vascular smooth muscle within the prostate and also the bladder. And this is to help older dudes with BPH, or benign prostatic hyperplasia, not hypertrophy, to urinate. Now, mirtazapine is primarily used for depression because it antagonizes alpha-2 receptors. Without any negative feedback on the release of monoamines such as serotonin and norepinephrine and dopamine, mirtazapine can make you feel real good, real happy, and it's good for treating depression. Now, the sedative effect may be a result from blocking catecholamine release. It is not yet understood how mirtazapine can also make you feel better, but also make you feel drowsy at the same time. It's just something you need to remember. It is also not quite yet completely understood why mirtazapine causes an increase in cholesterol levels and also can cause an increase in appetite. We now hit some graphs which you should really try to start loving. We are about to see what happens to heart rate and blood pressure when you give an alpha blocker like phentolamine after you give epi or phenylephrine. So let's start with epinephrine. Let's just look at our graph for a second. So this is before alpha blockade, and then this is after we give our phentolamine, and epinephrine has already been given. So remember that epinephrine stimulates beta-1 receptors in the heart, leading to an increase in heart rate, and therefore also an increase in cardiac output. This leads to an increase in the systolic blood pressure. We can see this is increased plateau up here. Notice how epinephrine causes a net drop in the diastolic blood pressure, and this is because of the beta-2 mediated vasodilatation of skeletal muscle vasculature. You have to recall always that beta-2 agonism causes vasodilatation. The strength of this effect is countered a little bit due to vasoconstriction in peripheral vessels triggered by epinephrine's weak alpha-1 activity relative to the beta-2 activity. Now, if we give an alpha blocker, like here, at this point in time, we give phentolamine. Now, we completely eliminate this alpha-1 effect. We eliminate the vasoconstriction. So what do we have now? We have unopposed beta-2 activity, which, as you can see, causes a larger, more pronounced drop in the diastolic blood pressure and completely flips the net effect from an increase to net overall drop in blood pressure. Notice the net pressure effect is positive here and will drop down to a negative effect. So what is this going to do to the baroreceptors? They're going to freak out and say, whoa, I sense a mean drop in blood pressure. Now we're going to activate a reflex tachycardia on top of the already beta 1 effects that epinephrine has on the heart. So don't mix drugs. Now let's compare this other graph. First, we must remember that phenylephrine is a pure, weak alpha-1 agonist. That's how it was designed. We can see that the alpha-1 mediated vasoconstriction causes a bump in the diastolic blood pressure. It raises the diastolic blood pressure because of the increase in total peripheral resistance. The baroreceptors sense this net pressure effect and cause a reflex bradycardia to decrease the heart rate. When we give our phentolamine at this point in time, you can imagine that it basically wipes out and suppresses the effects of the drug. If you give an alpha-1 antagonist after you give an alpha-1 agonist, you can just basically expect the effects to be gone. The most important things for you guys to understand about beta blockers are the location of beta receptors, mechanism, and side effects or contraindications. Don't worry about memorizing applications. That will mostly be step 2 stuff, but it can be helpful in your understanding of these drugs. Recall that beta 1 receptors are located in cardiac myocytes, including the specialized conduction system, the juxtaglomerular cells within the kidney. These release renin, and also on adipocytes. The beta 1 selective antagonists are atenolol, taxolol, esmolol, nebivolol, and metoprolol. Lastly, a weird one is acebutolol. It's actually a partial beta 1 agonist. And don't worry, this drug is never used, so you can basically just say, yeah, I know it's a partial beta 1 agonist, I'll never use it. Now, beta 1 selective blockers are usually cardioselective because they're helpful in their ability to decrease the sympathetic nervous system activity on the heart by targeting beta 1 cardiac receptors. This leads to a decrease in heart rate, a decrease in contractility, and therefore a decrease in cardiac output and decrease in myocardial oxygen demand. This is ideal in the treatment of angina or an MI, heart attack, right? We don't want to increase oxygen requirements. Now, esmolol is classically given in the ICU and as a drip form because it has a fast onset and a very short half-life. Its beta 1 antagonism decreases the AV nodal conduction speed, and a decrease in AV nodal conduction speed is helpful in terminating a supraventricular tachycardia, especially ones that involve the AV node. Nebivolol is unique because in addition to antagonizing beta 1 receptors, it also blocks beta 3 receptors, leading to an increase in nitric oxide production. Do you remember what nitric oxide does? Of course you do. It leads to vascular smooth muscle cell relaxation and therefore can help drop the total peripheral resistance. We like to do this in order to decrease the afterload for a struggling heart. You will need to know which beta blockers decrease mortality in heart failure for step 2, but not much for step 1. Nadolol, pindolol, propranolol, and timolol are all non-selective, indicating that they antagonize beta 1 and beta 2 receptors. Now, pindolol is never used because just like acebutolol, it's a partial agonist and we're not interested in partial agonism. It's too unpredictable. Nadolol and propranolol are non-selective beta blockers that are used in the treatment of varices because we want to block beta 2 receptors in the splanchnic arterioles to prevent vasodilatation and permit more vasoconstriction. Wait, what? More vasoconstriction? This doesn't make any sense. I usually don't like that, right? Let's look at this diagram. So in a situation in a patient that has cirrhosis, the fibrosis within the liver compresses blood vessels within the liver parenchyma, and now the vessels within the liver have a smaller radius. This creates a higher resistance, represented by the ohm symbol, so blood has difficulty entering the liver. This high resistance means that now we have a decreased Q or flow. This causes blood to accumulate within the portal vein and other portal veins such as the left gastric or coronary vein, sometimes called that by traditional dudes, the paraumbilical vein, the superior rectal vein, and the superior and inferior mesenteric veins. Now the endothelial cells lining these veins sense that there's an increase in pressure from blood backing up within the portal vein. The endothelial say, hey, hold up, I don't like this. So what are they going to do? They're going to release nitric oxide in order to vasodilatate and alleviate all of this pressure that they're sensing from the backup of blood. So the combination of dilated portal veins and high resistance within the liver redirects the majority of blood flow away from the liver. So where is all that flow going to go? Well, the flow is going to reverse, represented by that red arrow. This is pathologic flow. It starts going towards the portosystemic collaterals. This pathologic flow is going towards locations where the portal system anastomoses with the systemic veins, such as the esophagus, the umbilicus, and also the rectum. The anastomotic vessels where blood backs up get very large and swollen. We call these varices. The most important ones are the esophageal varices, because they have a 30% chance of killing your patient when they have them. 30% chance of your patient dying. These are caused by blood from the portal vein backing up into the left gastric vein, and also the esophageal veins that line the esophageal mucosa. Esophageal varices are a huge risk for an upper GI bleed and potential death, which is probably why they show up on step 1, step 2, and step 3. And I've taken care of 15, 20 patients with these on the transplant service. You have to understand this pathophysiology. By understanding this pathophysiology, we understand why we antagonize beta-2 receptors. This is to decrease the amount of flow of blood in the portal system. So why do the portosystemic collaterals appreciate you doing this? Why do they say, thanks for giving that propranolol? This is because less flow means less backup of blood and less engorgement of these collateral circulations. This is going to decrease the risk of variceal rupture and potential bleeding. Now, carvedilol and labetalol are also non-selective beta blockers that not only block beta-1 and beta-2 receptors, but they also antagonize alpha-1 receptors. Notice how they do not end in the traditional OLOL, which is useful and can help you remember that they are different from the other beta blockers. Let's quickly review some high-yield side effects. Some important things to remember are that you can never use non-selective beta blockers in asthmatic patients because beta-2 antagonism can actually trigger bronchospasm, and someone that has asthma, bronchospasm is their worst enemy. All right, now the most important one, impotence. Patients will just completely stop taking their beta blocker if they cannot get an erection or if they have difficulty ejaculating. The truth is that this has no longer actually been proven in the literature, but something that you need to remember just because it's always traditionally been taught that way. There is no real risk of hypoglycemia in diabetics, but we often still talk about this, and I also talk about it in the cardiology section because it makes you understand the theoretical risk based on the mechanism of these drugs. Now, cocaine. Here it comes again. Never do cocaine with your patients that are on non-selective beta blockers because loss of beta-2 mediated vasodilatation can leave you with alpha-1, just pure, unopposed increase in total peripheral resistance, which can drive the blood pressure through the roof.